Everyone, thank you Vikrant for this wonderful talk, and the topic given to me is seronegative autoimmune hepatitis. For those who are not aware what is autoimmune hepatitis and what is seronegative autoimmune hepatitis, seronegative basically means that we are diagnosing an autoimmune disease without the antibodies. So they do not have a positive autoantibodies, that is why this is known as seronegative autoimmune hepatitis. I have no disclosure, and this would be the outline of my talk. I'll try and finish it hopefully in time. Let's start with the concept of seronegativity. So I've tried to make a simplified diagram of what autoimmune hepatitis looks like. It's a multifactorial disorder. You have genetic triggers, external triggers. You have a tissue, in our case it's hepatocyte. There is an antigen which is going here. The antigen presenting cell takes up this antigen, presents it to the naive or CD4 T cells, which if the T regulatory cells are not acting well becomes an autoreactive CD4 cell, which then ensures there is an innate as well as adaptive immune response by CD8 NK cells and NK T cells, which causes this hepatocyte damage. So this is the classical belief or the thinking that goes under autoimmune hepatitis. So you can see predominantly it is a T cell mediated disorder. But over the years we have learned that B cells also play a role in autoimmune liver disorder. They can act as an antigen presenting cell to HLA class 2 in response to CD4 cells which release this IL-10, IL-4, IL-21. They can be converted into plasma cells, and plasma cells can do two things. They can produce these autoantibodies and they can lead to this antibody dependent cytotoxicity. I'll show the diagram. Yes, so you have a effector cell and you have a target cell. These are the antibodies. This is the FAB fragment, this is the FC fragment. This FC fragment aligns with these effector T cells, and FAB fragment aligns with the antigen, and this causes release of these cytotoxic molecules from the effector cells like NK cells and NK T cells, which causes the injury to the target cells. And also B cells can also release these cytokines which can lead to inflammatory cascade and cause hepatocyte injury. And this has been shown that this cytotoxicity has been shown to correlate with the biopsy findings of hepatocyte injury as early as 1987. So what is the role of autoantibodies? Their levels may correlate with your LFTs. If you see this slide, the IgM and the IgG antibody can correlate with your AST, ALT as well as in bilirubin in a single linear correlation. So as the levels may go up, hepatocyte injury may happen. Some studies have shown that anti-SLA titers may be associated with worse histology, longer remission time. But on the other hand, even if you induce or transfer these autoantibodies in animal models or during pregnancy, they have not been able to induce autoimmune hepatitis, and they may be a byproduct of autoimmune hepatitis or the disease per se, rather than having an independent causative association. So Ashray did this study, is still being under publication, in naive, treatment naive Wilson's disease, genetically confirmed cases. You see almost 31% patients already had a positive autoantibody, and almost 20% cases met the simplified AIH criteria. So they are not specific for autoimmune hepatitis. So the question is, are they specific? I don't think so. Are they sine qua non for diagnosis? Still, jury is still out. Are they pathogenic? Not sure. So what can be the reasons for seronegativity in an autoimmune disorder? Any autoimmune disorder. So one can be they are present but still not detected. Let me call it pseudo seronegativity, or they are truly absent. So let's start. What can be the reasons for seronegativity? It can be technical reasons, that we are using high dilutions. We are already diluting the by using whatever method we have, and we are not picking up lower titers. They can be initial intense antigen antibody complexes in which the antibodies are being used up with creating these complexes, and they are not being detected by your molecule. What you can do, you can rescreen them later, or if there are fluctuations in levels, you may miss at a specific point. If you are doing it, you may miss it. And some host factors are there. I'll show this here. So there have been multiple studies, case reports and case series only, in which they have found that in some cases of immune deficiencies, primary immune deficiencies, especially presenting in childhood, especially with this TNF-AIP3 gene, they have found that these children are predominantly those who will not generate autoantibodies because they have a deficient immune response. So you screen them if you have multi-system autoinflammatory conditions along with autoimmune hepatitis. So immunosuppressed, immunodeficiency, genetic factors, so you rescreen and evaluate immunity. Or if you are only screening the conventional ones, I'll show what are the conventional ones, you can screen other autoantibodies. So true seronegativity would mean that they can still act as antigen presenting cells, they can still cause cytokine production. What they cannot do is autoantibody production. So all other work of B cell is still being ongoing, but the only reason they cannot do is they cannot produce autoantibodies. So what does seronegativity means? Seronegativity still in some studies, I'll come back to these studies also later, it shows that inflammation or biochemical or histological injury is not different between the two. So they are still causing autoimmune liver damage, but the biochemically and histologically they still remain the same. So what is the problem statement? How common it is? If you look at the general studies, I mean to say overall autoimmune hepatitis studies which have not specifically looked at seronegativity, the prevalence varies from 0 to 22%, highest in our series. But if you look at the series who have specifically looked at seronegative autoimmune hepatitis as a cohort, it varies from 6% to 28%. What are the classical antibodies? These are the conventional ones that we use, ANA, SMA and LKM1. The non-classical antibodies which ideally should be screened in all are atypical P-ANCA, LC1, anti-SLA and AMAs. There are some other studies like ASC alloglycoprotein receptor, LKM1, actin, alpha-actinin, but most commonly what we go through are the first three, ANA, SMA, LKM1, and in our institute SLA and LC1 also. So is there a standard definition? Who are seronegative autoimmune hepatitis? There is no standard definition. Chaja gave this in 2012 for adults, not for pediatric population, predominantly excluding other disorders and negative for ANA, SMA, LKM and AMA. Pediatric studies have used the standard conventional antibodies ANA and SLKM1, especially other than this Maggio study from Italy, they have included AMA. So predominantly, if you are negative for conventional autoantibodies, you can be seronegative autoimmune hepatitis. When we published 2018, our seronegative rate was very high. It was 23%. It still remains high even after 7 years. And in which we had used the conventional antibodies along with P-ANCA at that time. So why our series had that high kind of autoimmune hepatitis seronegativity? We used the diagnostic criteria, standard classical histology, and in seronegative cases, we had confirmed our diagnosis by giving steroids and seeing the response to steroids. So, and in this case, we had 89% remission rate despite a high rate of fibrosis, and seropositives behaved as well as seronegatives in our study. So, was the methodology the issue? If you look at the series, predominantly what the ideal method for ANA, SMA, LKM1 is indirect immunofluorescence. In our institute, we use for ANA, SMA the same method, but we use line immunoassay for LKM1 and SLA. So, is that going to make a difference? In other series, they have also used the same methods predominantly, ANA, SMA for immunofluorescence. Predominantly, they are using immunofluorescence as the standard method. But for LKM1, we are using line immunoassay. So, but the literature and the guidelines say that if you have a known antigen, for ANA, SMA, we still do not know what is the autoantigen. But for those in which we have a target antigen, that is for LKM1, LC1, we are well within our rights to use line immunoassay for this. And this has been proven in the study published in almost 2002, in which they have shown that for LKM1, immunofluorescence and ELISA based or immunoassays do as well as each other. So you can interchange them for LKM1. But is it different from classical AIH? Is seronegative AIH different from the classical AIH? This is a very busy slide compiling 5 pediatric studies in which they have shown that barring one study which have shown that seronegative autoimmune hepatitis had higher propensity to cause more acute presentation, other series have not shown this kind of difference. So their clinical, biochemical parameters or the presentation remained the same. In adult literature also, a couple of series have shown that the IgG levels may be lower, they may have more advanced fibrosis, but overall they, with respect to their ALT levels, IgG levels, response to steroids or other immunosuppression therapy, the pattern remains the same.
And in our series also, Aditya is going to submit this soon. We have shown that barring a higher bilirubin levels and a lower fibrosis score, the response to treatment and the overall survival between seronegative and seropositive autoimmune hepatitis remained the same. So how do you manage? As we have shown that the response is not different between the immunosuppression therapy. So you can follow the same protocols. And one other concept was, some studies have shown that if you are finding a negative autoantibodies at the beginning, you may try and screen them later. These autoantibodies may appear in the natural course of the disease. And in studies have shown that you ideally should be doing serial measurements. But we do not do it. The main reason is, look at the cost. We still do not know how frequently should I repeat it. Should I repeat it 1 monthly, 2 monthly, 3 monthly? How long should I keep on repeating it? 1 year, 2 years, 5 years, 7 years? The cost is exorbitant. This is still the cheapest and the most reliable test you can get in anywhere in Delhi. But still, it is a costly test. Why would you keep on repeating if your management is not going to change because of that? And another concept of seronegative autoimmune hepatitis is with respect to the hematological manifestation. Some studies or some people believe that seronegative autoimmune hepatitis or seronegative hepatitis has a correlation with aplastic anemia in some cases. So it is known as hepatitis associated aplastic anemia. Some people have corroborated or correlated this seronegative hepatitis, seronegative autoimmune hepatitis with hepatitis A associated hepatitis associated aplastic anemia, not hepatitis A. So this study from McGuire had shown that in patients who have seronegativity with low seroglobulins may have a propensity to develop aplastic anemia. And baseline lymphopenia, in those cases had lymphopenia, can be a predictor for future hematological conditions. And in other series also, almost 32 cases, almost 50% developed aplastic anemia with a lymphopenia in almost 65% as a predictor of future hematological conditions. But are all seronegative hepatitis correlating with seronegative autoimmune hepatitis? I don't think so, because these are mostly infection triggered and none of these have shown on the future. Is there any autoimmune liver disorder who does not show relapses? And most of them had normal IgG. So I'm not sure that you can correlate them with each other. So what is the practical relevance? What you can do to decrease its incidence? Along with the ANA, SMA and LKM, you should screen for other antibodies. You can send the autoimmune liver profile that we use in our institute and you apply the original 99 criteria, not the simplified one. I'll show this difference because if you do not have autoantibodies, it is very difficult to get a definitive AIH diagnosis with the simplified criteria. But if you look at the 99 criteria, you only need 15 points. It is very easy to get 15 points if you are fulfilling all other things, because you may have negative drug exposure, you may have female sex, ALT levels, IgG levels, negative alcohol intake, positive histology. You can easily cross 15 points in original 99 criteria. So what is the gold standard test? Can anybody tell me what is the gold standard test for autoimmune hepatitis? Is it biochemistry, serology, histology? So the performance parameters of scoring systems are based on their compatibility with the gold standard of clinical judgment. None of these tests can never supersede your clinical judgment, and they cannot make a clinically untenable diagnosis diagnostically tenable. This was Raja et al. In 2016. So include seronegativity first. You need to improve your diagnostics. Do not neglect lower titers. In adults, the titers they are using for ANA, SMA are 1:80, 1:40, but in children we use 1:20, 1:10. We go down because any titer in children is significant. You should screen for other autoantibodies, not just restrict yourself to ANA, SMA and LKM1. You may screen later. We do not believe in this. In doubtful cases, steroid trial and response evaluation is the key that we follow in our institute, but should be done only in expert centers only. And clinical judgment remains the gold standard. These are my acknowledgements, and thank you.